What's up, guys? Welcome back to the Stress-Free NP. We're going to continue with learning about pharmacology. Today we're going to talk about calcium channel blockers. We're going to break down this drug into the different parts to help you study better and do better on your exams. So let's get at it. Calcium channel blockers. That's the drug name. Remember, we talk about the drug class or the drug name, calcium channel blockers. When you know the drug name, you want to know the endings. Does it have an ending that you can easily memorize? Calcium channel blockers does. It's PINE, P-I-N-E. You see a drug with the last P-I-N-E, it's a calcium channel blocker, even if you don't know the drug name. So let's break down the top 3 calcium channel blockers with the trade and generic names. Remember, we only need to know the top 3 of each category for your exams. First one, the most common one, amlodipine. Amlodipine is one of the most common calcium channel blockers you're going to see. It's our first offense when we prescribe for hypertension, and the generic name for that is going to be Norvasc. So you either know amlodipine and you know Norvasc. If it's put on a test, you know it's a calcium channel blocker. The second one is a very common calcium channel blocker, but it does not end in PINE, and that is diltiazem. Generic name is Cardizem. Diltiazem is used in the hospital or outside of the hospital. In the hospital, we actually inject it with an IV push. Out of the hospital, it's given oral or PO. Another third calcium channel blocker that's very common is nifedipine. Generic name is Adalat. Okay, these are the top 3 calcium channel blockers that you're going to see whether you're in the hospital or you're in the outpatient setting. So let's go to the mechanism of action. Remember, we break them down into different parts. So we did drug class, we did if it has an ending, we did the names, trade, and generic, and now we're going to go to the mechanism of action. So when you're talking about cardiac drugs, usually they are cardioselective or non-cardioselective or both. When we talk about beta blockers, most beta blockers are both. When we talk about calcium channel blockers, there's actually names for it. There's non-dihydropyramine and dihydropyramine. When we talk about non-dihydropyridine, it is cardioselective. And the way I remember that is the NON, the non and dihydropyridine, I take that O and I make it a heart, and that's how I remember that it's cardioselective. And then the other part is dihydropyridine, which is non-cardioselective. So these are heart or peripheral. When we're talking about peripheral calcium channel blockers, which are your amlodipine and your nifedipine, you're talking about how we block calcium from influxing into the cell of the smooth muscle. Remember, smooth muscle is non-voluntary. Skeletal muscle or striated muscle is the muscles in your biceps that you can use and work yourself. Smooth muscle is your involuntary muscle in your body, which is your heart, your lungs, all your organs. They work without you even trying. They just do it on their own. That's your smooth muscle. These are going to work on the smooth muscle. Smooth muscle is also your vascular system, your veins, your arteries. So when we talk about non-dihydropyridine or cardioselective and dihydropyridine, we're talking about smooth muscle, we're talking about coronary arteries, and we're talking about the peripheral systemic vascular system, mainly the peripheral arteries. So when we have the peripheral or dihydropyridine calcium channel blockers, your amlodipine and your nifedipine, you're preventing calcium from going across the membranes of these muscles. When calcium goes across a membrane of a muscle, it contracts. So if you block that with a calcium channel blocker, it's right in the name, you're going to stop calcium from going across the membrane of these muscles, and they're not going to contract, which in the periphery or the peripheral arteries, we're talking about dilation. So these are going to make these arteries, we're talking about, constriction. So these are going to make these arteries dilate versus constrict, which causes blood pressure to decrease. When we're talking about non-dihydropyridine or cardioselective, such as cardizem or diltiazem, we're talking about the same calcium channel going across the membrane of these smooth muscles, but now we're talking about the heart. And these mainly work in the AV node, or the atrioventricular node, which is right at the septum of the right atrium and the right ventricle. This is going to prevent impulses. The SA node is going to send an impulse to the AV node. The AV node is going to slow that impulse down to allow the right ventricle to contract, but it's going to contract more slowly. When we do this, we're going to prolong the time that it takes for the heart to contract, which is going to cause a lower heart rate, which in turn causes lower blood pressure. When we use cardizem or diltiazem in the hospital, we're really trying to control heart rate. A side effect of controlling heart rate or lowering heart rate is you can become hypotension or lower your blood pressure. So now we bump right into indications. Hypertension, that's a very common indication for especially your peripheral or dihydropyridine calcium channel blockers. Tachycardia or tachyarrhythmia, such as atrial fibrillation. This is one of the main medications that we're going to use for atrial fibrillation, and that's going to be cardizem, because that works right in the heart, right at that AV node, causing decreases impulses into that right ventricle, causing decreased pumping of the heart, which will lower the heart rate and in turn lower blood pressure. Side effects, top three, they're very obvious: low blood pressure, low heart rate. When you lower your blood pressure and lower your heart rate, sometimes you can get a headache, sometimes you can get dizziness. These are other side effects of calcium channel blockers as well. Nursing considerations, the same as any other blood pressure medication, beta blockers, whatever you're giving. You're going to want to check a blood pressure and you're going to want to check a heart rate before giving these medications. When you're giving PO and when you're giving the pushes of cardizem, usually the heart rate of the patients are in the 150s to 200s. But you want to check a blood pressure, because if their blood pressure is low and their heart rate is high, that might be an indication to speak to the provider and see if there's something else that needs to be done before giving this type of medication. Thank you guys so much for watching. Really appreciate it. If you liked the video, please like and subscribe so you don't miss any weekly video updates, and we'll see you next time.